Okay, thank you, Ahmed. I would like just to alert everyone here. There's a topic, I think, nowadays, late presentation is STEMI. I think it is a big issue related to COVID-19 era. So I would like to share these 2 slides or 3 slides from Twitter. It's just I left it exactly as same as it is. So there's the first case presentation. As you can see, it is a 68 years old gentleman who has been having ongoing history of chest pain for 9 days. And he has been advised by his son to stay at home and just to try to take some PPI. On just 3 days prior to admission, he developed severe dyspnea and palpitation, and then he attended to the emergency department. For those who are not a cardiologist, I will just show you exactly briefly. This is the apical window for transthoracic echocardiogram. On the right side, you can see the clip for apical 4-chamber view for a normal patient with a normal heart. As you can see, this is the apex here, which is healthy and contractile, and this is the mitral valve as well. On the other hand, as you can see, there's another video here. This is the echo for this patient. It is very clear, as you can see on the apex, there is a large apical thrombus with severe apical dyskinesia and severe left ventricular systolic dysfunction. And again, this is another case scenario from Twitter also. A patient, he presented the emergency department with ongoing chest pain for 24 hours. So he did not attend to the hospital immediately. I just maximize his ECG. As you can see, it is a very ischemic ECG. It is very clear this patient, he had inferior rest elevation with some reciprocal ischemic change on his posterior wall and right bundle branch block. I'm afraid I don't have a video clip for this angiogram, but as you can see, it is occluded right coronary artery with severe toxicity and multivessel disease. During the coronary angiogram, he became very hypotensive, and beside echo showed that he had pericardial effusion, as you can see, and then therefore he had CT scan, which you can see here. His CT thorax showed that he had pericardial effusion and rupture ventricular wall and inferior wall rupture. So I think it is very clear there is unacceptable delay in patient coming to the hospital during this time. And I think it is big challenging facing our medical community and facing our generation. And the healthcare provider, I think, should make every effort to tell the patient to go to the hospital if you had any chest pain or if you had any chronic illness or if you had any symptom. So I think the main reason for this delay in STEMI during this time is just very simple. Fear of the infection is likely the biggest driver for this delay. Now, how are we going to manage this patient? Because they will be different from the usual case we see from day to day. Would you take them direct to the cath lab, or would you recommend any fibrinolytic therapy? Dr. Muhammad, would you like to comment?
Yes, thanks, Dr. Abdalazeem. You're correct. We are seeing more and more of these late presentation, and this takes us back to the era even before thrombolysis, where we used to see mechanical complication, probably in about up to 5% of myocardial infarction. You had thrombolysis that dropped down to probably less than 1 to 2%. And then, of course, primary angioplasty, we probably less than 1 in 100, 1 in 1,000, in fact. And we have seen some really bad mechanical complications. And then it have to be treated. Of course, we know that their outcome is not as good, because when you have a VSD or you have a free wall rupture, that the outcome is not favorable at all. It's education, and now there has been some change. I mentioned it a little earlier in the early part of the pandemic. Fear factor was playing a major role in all what we did, and also what the patients have done. We are starting to see a little bit of a trend toward more presentation and early presentation. I think people are getting the message, and thanks to the British Heart Foundation, to the British Cardiac Society, and all the probably media outlet and some Twitter and all different aspects of education, telling the patient that hospital are still running exactly the same. And if you have chest pain, if you have any symptoms, don't hesitate. The methods are in place to protect them when they come to the hospital. And it's much better to get your chest pain and heart attack treated early on rather than wait and have a complication like these.
Okay, thank you very much, Dr. Mohammed. Had anyone had any more inputs in this point?
Yeah, I just think because we're seeing late presentations, it's also important on how you manage these. And that's why I think taking them to the cath lab is very important, because they have a lot more thrombus load also. And the way we deal with them is slightly different than what we would have done previously. And I think, again, it's important that you recognize that these mechanical complications can occur, especially VSD and MRs. And all over the world, I think cardiologists are having to deal with this more and more. And you see a lot of case reports out there of patients coming in VSD and MRs, which we've not seen in the last 10 years or so. It's very rare we ever see one, basically. And again, like Mohammed earlier said, I think because the education only in the last couple of weeks, I've noticed last week is the week when I've actually started seeing more patients coming in with heart attacks to our chest pain unit, whereas previously we hardly had a few patients on the chest pain unit. So I'm glad at least people are understanding that it's important that when they have chest pains, they do need to come to hospital and get themselves checked.
Thank you. Dr. Mudassir, do you want to?
Yes,
add anything?
I just wanted to add that there should be a clear guidance right from the top, which is from the Department of Health, from the government, Public Health England, and also should be a clear-cut message locally from the trusts into the local newspapers and other print medias and electronic medias that education in this situation is very important, and we should be explaining this to the patient that there is a risk of infection, but heart attack patients have a definite available treatment which improves the survival and reduces the risk of long-term damage. So they should be availing those treatments from their respective hospitals. So I think there should be a clear-cut message right from the top to the local level, and from local level to the local media and public, that if, especially with heart attack and stroke patients, if they have the symptom, they should come to the hospital as they've been advised in the past, because time is money, and it's important that we get these patients into the hospital as soon as possible to give them the treatment and prevent long-term mortality and morbidity.
Thank you very much, Dr. Baig and Dr. Yusri and Dr. Raja, Dr. Hind, Dr. Abu Bakr.